we wish to underline that what we see in India having world-class healthcare infrastructure in many parts, though dismally centered to its urban geographies, is an outcome of efforts, dedication, and passion of many of these doctors and entrepreneurs who have taken up the responsibility of building this from scratch. We are hopeful that this pandemic will herald an era of India putting the healthcare first, and all our resources, be it in public or private, will be rallied to achieve a healthier, happier India ready to prevent or combat any future pandemic. With this, I would like to welcome our esteemed guests today, those who represent this grit and resilience of private healthcare sector and are some of the finest contributors of what we see as healthcare infrastructure around us. So let me welcome Dr. Dharminder Nagar, the founder and managing director of Paras Healthcare. Let me also welcome Dr. Harish Pillai. He is the group CEO of Aster India, Aster DM Healthcare. Let me also welcome Dr. Dinesh Batra. He is the co-founder of director of Ujala Cygnus Healthcare Services and is regarded as a well-known healthcare management expert with over 30 years of experience in the industry. So let me begin this session without much delay. And I would request Dr. Dharminder Nagar to give his opening remark and let us know that how he has been trying and his Paras Healthcare has been trying to bridge this critical gap of healthcare in our society where diseases are definitely universal, but healthcare is not. Dr. Nagar.
Good morning, everyone. Thank you so much, Kamal, for inviting me at this platform. You've done such an amazing job in this time of crisis and need. You've helped buck up each and every healthcare provider, healthcare worker, and I think this gratitude week definitely will help us as healthcare providers to keep us motivated, keep going at it, and working even harder for society. The question you've raised regarding accessibility, and I think that has been the conundrum for Indian healthcare. We simultaneously claim that we are world-class in our healthcare provisions, and we are. But that is in patches, that is for certain areas, that is within certain geographies. You will notice that as soon as you leave a metro city, the healthcare moves from world-class to non-existent. Let's not even call it a class, it is a non-existent. There is huge regional discrepancies. As you would notice, Harish, who manages healthcare in south of India and west of India, there is immensely different healthcare provision between south and north, between east and west. The gap in Indian healthcare is not Indian healthcare alone, gap is regional as well. And I think the challenge is to create a healthcare enterprise or a healthcare system which takes care of these regional imbalances as well. I particularly work in North India, Paras Healthcare works in North India, and North India is within India much behind in healthcare provision, at least in tier 2, tier 3 cities. When we started Paras Healthcare, now more than a decade and a half ago, we always thought that we'll provide excellent quality healthcare for the middle classes. Although our first hospital was in Gurgaon, there was a huge gap in accessibility within Gurgaon. There was never a super specialist healthcare provision in Gurgaon when I started Gurgaon. In retrospect, now I perhaps would like to say that it's too much of healthcare provision in one's city, but at that time, there wasn't any provision. We decided to move to Bihar. Again, there was actually non-existent healthcare. There was some government sector, there was some private sector, but on a super specialty level, under one roof, healthcare was missing. And we've started Darbhanga, we've started Udaipur. But these are very, I must confess, this is just tip of the iceberg. I mean, I haven't even completed 1% of the gap. I mean, my provision, Paras Healthcare's provision in these areas does not cater for 95% of the population yet. There needs to be hundreds of Paras Healthcares in north of India to enable healthcare accessibility, which is quality driven, which is value for money, which is for middle classes, hopefully for all classes. Hundreds of hospitals are required. When I say hospitals are required, government loves to talk about beds, ventilators. Nowadays, ventilators is the in thing, so they love to talk about ventilators, all these kinds of gadgets and beds and infrastructure. Healthcare is not about beds. Healthcare is not about buildings. Healthcare is not even about ventilators. Healthcare is the man behind the machine. Healthcare is about soft nursing care, clinical care, training of those people. And I think that is the gap, which is even worse. When we say there are no hospitals, I feel that it is easy to create the infrastructure, but the human capital is completely missing. I hope during these COVID crisis, one thing society in general may have realized, that healthcare is the most important thing for a nation, for society, and for the world as a whole. This COVID crisis, as finally some of us are clinicians, doctors, healthcare providers, are at least in one way, slight sense of pride and happiness has come in that, oh, finally people in society have recognized that nothing moves without healthcare provision. The whole world can shut down, but we will continue to work. We will continue to provide services. Everybody can go home and shut their doors. Healthcare cannot afford to shut their doors. We will not shut our doors. We will always work. We will always provide, and we will always care.
Thank you so much, Dr. Nagar. The important thing you said that healthcare is not about buildings and then the ventilators or beds. And we have seen that situation also emerging in our country where bed, ventilator and infrastructure were put in place, but there were no one to care. And the care is the most important aspect of healthcare. So let me go to Dr. Harish to take you said about his massive work in the southern part of this country. And before I come back to Dr. Batra, who is serving a very, very different aspect of our North Indian landscape. So Dr. Harish Pillai, how your Aster DM Healthcare is contributing to bridge those gaps which we see in our healthcare for decades, and how you are playing an important role also during this time of pandemic. However, we do appreciate and we believe that healthcare infrastructure is not only evaluated as per the performance in pandemic, because what you people are doing and managing on day-to-day basis is much larger a piece and a burden on humanity than the pandemic itself. So Dr. Harish Pillai, your view about Aster DM's contribution and how you envision to make India's healthcare system not only world class but equitable to all.
So thank you, Kamal, and I also echo the same sentiments of Dharminder about the fantastic work which you have done. Many times it's very difficult to read the newspaper. I don't watch television at all. I don't watch any news channel because why spoil your mental health? So since many years, I don't watch any TV. So I'm kind of relaxed because I don't watch any news. But still, I'm one of those old-fashioned people who still like the smell of newspapers. So I still read my newspaper or a morning cup of tea. And sometimes it breaks your heart to see healthcare workers around the country being traumatized, sometimes for no fault of theirs. So I guess this is a wake-up call, collective wake-up call for our country that when you talk about strategic sectors, right, we usually talk about defense. thanks to the Chinese at Ladakh. It's always the headline news, but we never talk about healthcare as a strategic subject. So my hope is that there will be a pre-COVID India and a post-COVID India. A post-COVID India where I feel that every politician worth his salt across the country will have healthcare as a main point in his manifesto. And I'm sure that the constituents of our country, wherever they are, they will demand healthcare as a fundamental right. When Dharminder talked about this regional disparities, it's very true that South India, when you come to some parts of South India, you don't feel like you're in India. You know, I consider India as the United States of India because it's fascinating. Not just linguistic differences, cultural and ethnic differences, but there is clear-cut macroeconomic differences. Like one of my favorite terms in economics is the Gini coefficient, which talks about equity in society. So to give you an example from a state where we are one of the largest players, as the state of Kerala, the Gini coefficient there is unlike any other state in India because the whole state is one urbanized network. You can call it from north to south, Kerala is one urban state. And you don't have village from the traditional North Indian description of a village at all in Kerala. You'll never find that. Why is it like that? It's just that from a socio-political point of view, right from early 1950s, like 1957 to be precise, the state democratically elected a communist government to power. When Nehruji was the prime minister, we had EMS Namboodiripad, the communist leader of CPM, elected as the chief minister of the state. So from a left of center ideological perspective, there has been a huge focus of sustained investment in social sectors, education and healthcare. So with the result of multi-decade, so in Kerala, every 5 years, the party will change. I mean, that's how the people vote. So irrespective whether it's a communist or the Congress coming to power, the investments in social sectors have been sustained over a period of time. And fascinating that because the high literacy level, 100% literacy level, the reverse sex ratio, the female literacy level is so high. Therefore, you are blessed with some of the best macro health indicators, not just in India, but probably among OECD countries. That's the state of, and this pandemic has really shown that if you really invest in your public health system, especially your primary care, it will pay dividends long-term for society overall. And so that, I think, is one big take-home that when I talk about post-COVID India, I hope that the citizens of this country and the political class will wake up that they need to consider health sector as a strategic sector. And one number which I always plead in all public forum is we need to ramp up our investments to 5% of GDP, both at national level and state level, to bring up a certain level of equity in the healthcare model. I don't think society is sustainable if there is such a big gap in accessibility. Your question to all of us today is that how do you address this disparity in accessibility? And I think it's the most ultimate form of cruelty when your barriers of your economic disposition of birth prevents you from accessing quality healthcare. Then there's something wrong in society. So that is why I feel that states across the country need to invest much more in their public health system. And Dr. Dharminder made an important point that we can't be prisoners of the past. The earlier, I mean, thankfully now the Medical Council of India has been reformed to the National Medical Commission. But earlier it was kind of bizarre that we got fossilized in time. It was based on the British GMC system. GMC has evolved. If you look at the GMC structure, you have stakeholders from the community to whom you're producing doctors to actually be in part of the governance system of GMC, not the Medical Council of India, which we had before. But it's good that the powers that be has made some critical transformation in the past 7 years, I would say. So to list a few of them, I'm pretty excited about this transformation in the regulatory mechanism for education, mainly the NMC. I think that will double the capacity of professionals in the sector. And Dr. Dharminder's point is quite valid. It's the soft skills, the human resources in the supply chain, which will enable sustainability of the sector. So I think these kind of reformations which is brought in will take us in the right direction in the next 10 years time. It's a decade vision. what the country has above it, to double the number of graduates and postgraduate doctors, to bring the disparity, to eliminate the disparity between MCI trained doctors and the National Board of Exams, the DNB cadre in the country. That was an artificially created disparity. Now it's no longer there. I think the reformations taking place in the nursing council is also important. To, we are now pretty excited to bring in a cadre of nurse practitioners, specialty nurses. In select disciplines, the nurses can also be like barefoot doctors of China, for example. They're also allowed to prescribe. So I think that's pretty good. The Healthcare Council of India has also done phenomenal work in developing a plethora of skilling programs where you can, when you deconstruct most of our work, it's all repetitive tasks. So repetitive tasks could be handed over to a skilled healthcare worker who is in huge demand, especially in the context of a pandemic. Like many of us who are trying to manage, to provide, continue to provide service in a pandemic situation. What is the challenge? What we're facing is, for example, home care, quarantine. You have this COVID care centers where people are under quarantine, and you need healthcare workers to look after them. So you're talking about an army of phlebotomists. You need to have those, those technicians who are in short supply across India. And people are willing to pay premium, but you're not even able to get a nurse. So that's the kind of challenge which we're facing in terms of the human resources part. I'm also very delighted about, there is a controversy and debate about it, probably for the right thing, but the fact that the Clinical Establishment Act has been rolled out across different parts of India, I think it's a good thing that there is a grievance addressal mechanism for the common citizen, that if they have a grievance against the healthcare system or the provider, how do you go and approach the system for taking care of their norms? So I think it also brings about a minimum assured quality of care. So that's one of the core principles of the Clinical Establishment Act. The Big Bang reformation which I can reflect upon is, of course, Ayushman Bharat. The point which I made earlier about economic disparity, I think the intent of the government to create Ayushman Bharat is highly laudable. We can talk about it that, there are critics who talk about that it's not a perfect system, but I look at it from a different point of view, that the intent and the idea is wonderful. But at the same time, the sectoral investments making for curative and therapeutic medicine should not rob away the required investments in primary care and also public health systems, which I talked about before. So there has to be a balanced approach between sustained investments in primary and public health, and also in into the world's largest insurance network like Ayushman Bharat. Something which is also a collateral benefit about Ayushman Bharat is the government of India is right now able to get data from across the country because it's backed with a very good digital backbone. You're able to understand disease patterns across the country, mostly in NCDs. You're able to see consumption patterns. You're able to look at pricing patterns. So all this data which is being collected at the central level, I think it will help us to have targeted and precision policy. When I talked about the United States of India, actually India at a political level is based on the districts. So when you consider the district, the disparities between the various districts of India is something which we can address, because clearly there are some districts which are in the red zone. They have not just healthcare, they have nothing. So it's a bit of a shock when you go to those districts. So you can't afford to have that kind of a situation, especially from a national point of view. As concerned citizens, we all aspire that our country truly gets its place in the committee of, if we aspire to be a superpower, the superpower is not a definition of your political, strategic, or your military strength. It's also a reflection of your social standing and human developmental index. So I think that's what my dream of post-COVID India is going to be. Talking about Aster, we are spread across 5 states, 13 hospitals, mostly in South India, Kerala, Karnataka, Andhra, Telangana, and we have a presence in Maharashtra. So we have tried our best to extend services not only from the hospital side. We have leveraged on technology quite a bit, because in the initial stage when the Prime Minister announced about the Janta curfew, there was a lot of anxiety prevalent among citizens about COVID type of symptoms, and most of our doctors and institutions got jammed up with calls. So we looked at launching an AI-based app which will answer most of the questions of the citizens. So that was the first initiative which we did. We quickly moved on to the telemedicine platform in terms of e-consult services. We are extremely grateful for the Government of India and the National Medical Commission to bring out those guidelines on teleconsultation, which is much needed for a country of our size. And I really believe that technology would be a key bridge to overcome the human resources gap what we have in this country. Third aspect is home care, what we talked about. I think home care is something which was there only in urban centers, but I think there is a great role for home care in semi-rural areas, in tier 3, tier 4 cities, and also in rural areas. I think that's very important. Fintech plays a key role because that's something thanks to the push by the Government of India in promoting digital finance, whether you have your Beam app or others. So I think fintech also has removed some of the bottlenecks which COVID-related issues created in the system. So in our own way, we have tried to look at it. The last point, addressing Dr. Dharminder's point, is what can we do to increase the pipeline for human resources? So we are also working with the Healthcare Skill Council to have nursing care assistants, for example, because at this point of time, all hospitals require an army of nurses and nursing care assistants, so critical care assistants or nursing assistants. So we are trying to ramp up that program across our network hospitals. So I hope this answers your question. Thank you.
Oh, thank you so much, Dr. Pillai. You very well highlighted the multiple aspects which are playing a role and are actually bringing out the kind of outcome which we saw during this pandemic. And thankfully, despite all those hiccups initially, India is doing fairly better than other countries in the world. But it's still I think a big fight and a long fight. Let's see how we are able to continue to put up this kind of response to the pandemic and other areas. Dr. Batra, Dr. Pillai talked about this geographical discrepancies which we see in our healthcare. The kind of area you are serving to is very unique. We don't have even this geographical discrepancies from Delhi to Darbhanga, or maybe from let's say Kochi to or maybe I'll not take Kerala as an example because Kerala has a much better health infrastructure, but maybe maybe Hyderabad to Guntur, metros like Delhi, where you see a South Delhi may be having a much more concentration of healthcare, and maybe the East Delhi or the the peripheries of Delhi may not have that kind of healthcare system. And in the time of critical care or emergency, maybe to reach to a right hospital within the city itself, a person may have to travel for 2 hours, which is equivalent to traveling almost 100 kilometers. And you have tried to provide healthcare in those areas, and also in those areas which are the satellites of large metros, like your hospitals are a lot in Haryana as well. How do you see this geographical discrepancies, and what are the unique need of these areas, and how you are addressing that problem, and how you have been building hospitals which can provide this essential, critical, tertiary care and secondary care to the people who need, and in time within their access.
Thank you, Kamal, for this wonderful opportunity to be part of a panel where eminent people like Dr. Dharminder Nagar and Harish Pillai are there. And Dr. Nagar, very frankly, has been a source of inspiration for all of us. He was one of the pioneers who started work in Gurgaon when nobody thought that the kind of hospital he's making in Gurgaon will be able to survive. And going from there, he has taken healthcare to the areas which are far from imagination for most of the people in terrains of Bihar and other places. And simultaneously, I must compliment you for the kind of week you have celebrated and the other activities this organization is doing. And best wishes from me and Ujala Healthcare for these activities. as far as gratitude to the doctors are concerned, that's a tremendous transformation in last 4 or 5 months, for about 30, 40 years in existence in healthcare. Actually, those people who started the career in 80s and they decided to become doctor in 60s or 70s, they actually got so much of disappointment while they came into the actual stuff of service. And they found the very reason because they became doctor has actually vanished from the scene of service. So the whole thing got totally commercialized. And so there was huge frustration and disappointment. And at the same time, that probably was one of the reasons of starting something what we did 10 years back in the name of Cygnus Medicare. But this whole issue of COVID has turned the whole thing upside down. It has brought back doctors into glory. And probably we have started feeling proud again. And if you see, there's something to do with the mindset of certain people in society, the mindset which forces a particular person to choose a profession like becoming a soldier in army. And I used to think that the soldiers, when they decide to become an army man, probably they are trained and they are prepared to lose their life. But doctors are not trained that way. But despite that fact, in the last 4 or 5 months, we have very clearly seen the kind of devotion which is unimaginable. Everybody salutes this profession and the people who have actually sacrificed their lives, and many of them are still struggling to survive. So with that thing, I want to start the topic which you have given, that the geographical discrepancy in North India and India as a whole. And if you see 70 years of existence post-independence, and where we should have been in healthcare and where we are. Actually see about, if you go back to 10 years, let's say in early 2000, you would be surprised to see the most of peripheral areas at district level or beyond district, tier 2 or tier 3 towns, lack the emergency services other than maternity. So if you see 3, 4 major situations, emergency areas, like if a person has a heart attack, if a person has trauma, if a person needs any medical intensive care because of any reason, maybe it is respiratory distress, maybe it is poisoning, maybe it is any other reason which require intensive care, this guy was shunted off from that village or block or tehsil or a district and advised to go to a state capital, maybe in our case, Chandigarh, Delhi, Patna, Jaipur, etc. And even from those the state capitals, they would ultimately fly to places like Delhi. And I remember, as Dr. Dharminder was telling about a north-south gap, many years back, even for a CABG, North Indian people, even from places like Delhi, used to travel to South India for getting a bypass surgery done. So that is the kind of disparity we had. And that is the kind of disparity which existed in North India till 10 years back. At that point of time, few of us, Dr. Nagar is here, and the Cygnus also studied this evolution very closely. And we found out that whatever tertiary or quaternary care which exists in this country is still limited to metropolitan cities, at least throughout the country. But if you go slightly beyond, if you start, even today, if you see the tertiary care, it is at a low level in state capitals. There are many state capitals which do not even have an organ transplant facility even today. So that is the kind of gap. So going beyond a state capital in district centers, even today we are struggling to provide low tertiary care. So that is the kind of situation where we are in. Look at and it's not only accessibility. If you ask me, what is the reason of accessibility not being filled in 70 years, I'll straight away tell 2 major reasons. One is the affordability issues of the public, which did not allow private sector to grow in those areas. And second, inability of our political system to invest in healthcare. And as we are still struggling to invest less than 2% of GDP in healthcare, and Harish has rightly said that it should be at least 5%. So there are these two major reasons that we couldn't develop the accessibility in peripheral towns. This government particularly has done a wonderful job by addressing the affordability issue by means of Ayushman Bharat, which still is in a nascent stage, which still lacks awareness in the peripheral towns. But I think this will go a very long way in improving the accessibility. So we had been talking about let's say 60, 70 years that doctors are not there, nurses are not there, and that's the reason of inaccessibility. But now things will dramatically change because of affordability issue has been taken care of. Accessibility will definitely follow. And of course, the quality accessibility will still have to wait for some more time, but it will definitely follow that also. And Ayushman is very particular about taking care of quality issues from day one. So keeping these things in mind, about 10 years back in 2011, we decided to sort of do whatever we could do. And so we started opening these hospitals in peripheral town like Sonipat, Panipat, Karnal, Kurukshetra, Kathal. Then now we have one in Kashipur, the second in Kashipur, Varanasi, and a few peripheral areas of Delhi. As you rightly said, geography of Delhi is very heterogeneous. The peripheral areas of Delhi are as bad as Haryana. The moment you move out of Delhi, as Dr. Dharminder said, there is non-existent healthcare. While we opened the first hospital in Sonipat, we found out that most of the clinics or nursing homes would close down at 7, 8 p.m. And if any emergency lands up even in a hospital, private hospital, he will be politely told that doctor is not here, take this patient to Delhi, because they understand that beyond 7, the kind of emergencies which will land up, they'll not be able to tackle them because they don't have the specialists or super specialists. So they'll politely refer those patients to. So that was the condition 8 to 10 years back in places as close to Delhi as 20 kilometers. So there was non-existent healthcare. There are a lot of work which has happened in last 10 years, but still we need to wrap up this very fast. And I would say there are many private players need to join hands together. For example, there are 3 people sitting here, and there I'm sure many more who can work together and create something very meaningful in a very short span of time. That's what I feel.
Thank you so much, Dr. Batra, for highlighting, and then you highlighted some of very important point. One thing which you mentioned about that, the people who started their, let's say, medical practices around or career around in 80s and saw that the scenario has changed dramatically. You mentioned about commercialization, but apart from commercialization, what of late, we have been seeing, and I belong to little, I think the later generation. So we are also seeing a lot of distrust. And I would like to go to Dr. Dharminder Nagar, that the increasing distrust which is happening both from the society side and also many times being highlighted or aggravated or maybe extended further from the government side by the media. How do you see that, when there was a time which I heard from our seniors only, that there was a time when doctor or civil surgeon used to be respected like the district magistrate or the superintendent of police in a society. Now the trust and the respect for the doctors have got a severe beating. How do you see that this challenge of getting more resources, more human resources, more doctors, more nurses, more paramedics joining in in a society? And I'm talking a little bit of before COVID-19 time also, and also within COVID-19, where society sometime also end up distrusting and sometimes even bashing up their medical professionals for something which is maybe a alleged or a perceived negligence, or maybe just not living up to your inflated expectations?
I think this trust issue is a multifaceted one. If we try to answer this just with one go, that we can resolve this trust issue in one go, it will not happen. As medical professionals, we have to realize that people come to us in times of stress and unhappiness. It existed before, but expectation 30, 40 years ago from a doctor were very, very minimal. So if you went to a doctor, you went to your local practitioner, if you survived, wonderful. If it didn't survive, that was the expectation. Now the expectation has been mixed with financial issues as well. So the perception of society in general is healthcare should be free. That is the expectation. I don't and should not pay for healthcare services. If I'm paying for healthcare services, it is a majburi. It is because somebody is kind of cheating me out of something. And God forbid, if there is a negative result, post my admission, post paying, let's say 4 lakh rupees, then obviously somebody has to be held accountable. Whether it is justified, whether there was a medical negligence or any sort of negligence, it does not matter. Because I spent 4 lakh rupees and I expected 100% outcome, I should get the result. And if I haven't got the result, somebody is at fault. In this, our professionals and we ourselves are also at fault. We in India, our counseling skills as clinicians, as hospitals are very, very low. We do not sensitize the patients for negative outcomes. I think I practiced briefly in England, and the only thing I realized is that the counseling skills of ours did not even exist. Any doctor abroad will take you through the positives, negatives, probable outcomes, and we don't spend enough time doing that. So it's a financial issue. It's a training issue from clinical side. And how do we bridge it? I think bridging is going to be a long haul. I see that when patient is not paying out of pocket, somebody else is paying, his natural inclination to complain always comes out. So how do we ensure through Ayushman Bharat or through medical insurance that society pays out of pocket at the minimal level? We don't ask the patient to bring out wads of cash. Ki ji, ye 1 lakh rupees hai, please do my surgery. I think insurance, whether public or private, is the need of the hour. And if as healthcare providers, we have to grow, we have to sustain, and we have to build trust, I think we should all make sure that society is moving in that direction.
Thank you, Dr. Nagar. So you are of opinion that the financial distress which comes along with the the healthcare distress is many times driving or pushing people to kind of lose respect or trust to the healthcare system, because I think the innate feeling is that they should not pay. Dr. Harish Pillai, and this is the last comment, Dr. Pillai and Dr. Batra, I'll be coming after him to you. We are getting to the closure of this session. Dr. Pillai, you said that you are kind of dreaming about an India which is 5% of GDP being spent on healthcare. People should not be paying from their pocket, and you also want that every politician should be having the first agenda item should be that they will provide healthcare. But when Dr. Nagar says that any person and every person who is coming to the hospital is having a feeling that I should not pay for health, how do you see that? Is it matching with that? Because if as a citizen of this country, I believe that healthcare is most important and I should not be paying for that, do I really go and vote for that? So how do you see that happening?
So, Kamal, it's a very complex question what you have asked. It takes me back to the famous quote of Rajiv Gandhi, our former Prime Minister, when he said that एक रुपया जो दिल्ली से निकलता है, वो जब जमीन तक पहुंचता है, it is 10 पैसा. तो जो 90 paisa, it just disappears in the system, right? So the biggest problem, it's a cultural issue which we as Indians need to acknowledge, is corruption in our society. There's something wrong with us. this popular term of jugaad, no? Sab kuch chalta hai. I think it's time to put a full stop कि सब कुछ ऐसा ही चलेगा तो कुछ होगा ही नहीं. So there is something we have to do soul searching, that why are we always trying for jugaad, like trying to short. We don't want to stand in a queue. हम लोग the old days, of course, nowadays nobody, I mean, thanks to streaming platforms is different, but we are not even disciplined enough to stand in a queue to see a cinema. We have the black ticket black mein milta hai na. So that kind of culture, it's a cultural issue which we face. So coming to your question is that if there is an efficient management of limited resources, it can be done. See, that's why I gave you the first example of, you have to look at the district level. We talk about the Indian Administrative Service, right? The so-called the steel framework of India. But there are good IAS officers, there are average guys, and there are terrible guys. I know of so many districts where there are phenomenal IAS officers. Because of that individual officer's presence, the healthcare system is just transformed dramatically. But if that unfortunate soul has been transferred out due to some other reason, that's it. It's going back. So we have a problem in terms of also insulating our systems, our governance systems. I have also talked in public forums that why is India not having a central cadre for managing health? The Dr. Batra ne bhi bola tha pehle that most public hospitals, the senior most doctor, right? The senior most doctors made the medical director or the medical superintendent. That's a culture in India. Now, it doesn't mean that a very senior clinician who is very good in clinical medicine is also a good manager who can manage limited resources at his disposal. So there is a systemic issue. Why are we not having a cadre? I give an example of France. France has got giant public hospitals, which is like 1,500 to 2,000 bed size. But the director of the hospital is always a professional who comes from a public school. You need to have like an equivalent of an MBA, and very young professionals managing such large systems. I feel there is an employment opportunity in our country to professionalize the management of public hospitals in the country. So that is something else what we have to do. This, the expectations, what you talked about consumers. So that's also, I guess that the distrust which happened is also when that economic transaction took place, I guess there's a mismatch in expectations. If you are fond of old Hindi cinema, we always find that the Dr. Kaka or the Dr. Nana holding that bag, he's always there. The friend, philosopher, advisor to the family in Hindi cinema is the doctor, Dr. Chacha. But you always find that when the Dr. Chacha does his stuff and goes back, unko fees dene ka hai. So fees is, obviously there's a financial transaction. So I guess the entire difference in expectations came somewhere in 80s. I would say mid 80s is when this transformation and expectations changed for the society. But like Dr. Dharminder said that I feel that in the next 5 to 8 years time, this out-of-pocket expenditure part will come down, either through public financing like Ayushman Bharat, or private insurance will step in, or there would be a hybrid model where employers, whoever, whether you're in formal or the informal sector, the employer will also pitch in to give some kind of a health coverage. So that's a way forward. It's very clear that out-of-pocket expenditure is definitely going to come down. Doctors, we also have to do some soul searching. Like one excellent example from India is the National Cancer Grid. The National Cancer Grid is, I'm sure there will be a case study which will be done where they have looked at the objective evidence-based treatment of cancers around the world. Like in the old days, we had few eminent doctors who were considered to be the godfathers for medicine. But the National Cancer Grid is basically a data-driven algorithm where whichever part of India you are, there is a scientific objective pathway for treatment of cancers. The big collateral benefit is the cost of care has dramatically come down, and those kind of acquisitions, people, because of information asymmetry, you always find that there's an adverse outcome, the doctors to be blamed. So the National Cancer Grid has actually thrown all these things out of the equation. So the corollary which I'm trying to say is that the same objective application which took place at the National Cancer Grid can be applied for many other non-communicable diseases, whether it's coronary artery disease, whether it's orthopedics, neurosciences. So if we do that, and we have the technical, intellectual ability and also the science behind it. So it's just a matter of time when data-driven treatment of diseases will actually remove this kind of misconceptions which are there in the minds of patients or their family members.
Thank you so much, Dr. Pillai. Your point is well, taken, and I think definitely in the coming 5-6 years we should be seeing a very, very different India, and this pandemic will trigger some that change as well. Dr. Batra, a quick remark from your side. You are contributing immensely on Ayushman Bharat, one of the I think most talked about, appreciated scheme across the board. But we at the same time also see a lot of apathy from the government sector to the private sector of healthcare, especially from the lawmakers and from the regulators and all that. How do you see this relationship going forward, especially when they have also realized in time of COVID-19 that government alone cannot provide the healthcare to this massive country, either out of pandemic or during the time of pandemic. So do you see that this is going to change completely the relationship between these two very, very important partner going forward? Dr. Batra, are you on mute, I think, Dr. Batra?
Yeah, that's very true, actually. The biggest catalyst for this change is actually Ayushman. And although there are a lot of apprehension still in the mind of many healthcare players, particularly private healthcare players, and actually it has to be understood that this scheme actually is designed for all those healthcare service providers who are providing service in peripheral towns. And the objections coming are mainly from those corporates who are providing services in metropolitan towns. So that has to be very clear. And actually this is going to not only increase the accessibility and affordability issue, and this scheme actually has to ultimately transform the trust deficit also. And this trust deficit which exists between patients and society on one side and doctors on the other side, as Dr. Dharminder has rightly said, this is directly linked to the payment out of pocket. As we progress and evolve towards a stage where less and less people are paying out of pocket, this problem will go down, and we see the trust deficit almost non-existent in Ayushman patients. And so because they're not paying anything, they do not have, and their ticket size is so big that all their diseases are covered for a year. So insurance patient still cribs because of he's worried about his ticket size. But as far as Ayushman is concerned, that issue does not exist. And going forward, this will be a major bridge between the service providers on private side and the government side. And if finally government decides to be a uniform third-party payer, the role of it takes over the role of a payer rather than a service provider, it will go a very long way if they allow private healthcare to work as a quality service provider, and they transform themselves into a maybe some kind of preventive and the wellness side of it, and they take care of the diseases like pandemics and other stuff, the awareness part and the root cause of all those issues, and dedicate themselves more towards research and innovations, then probably leave the service part and the service provider part to the private sector, and where the patient has to pay less and less. Even today, about 60% of population does not have to pay out of pocket, because around 40 to 50% comes under the Ayushman, around 6, 7, 8% comes under insurance, and rest comes under some or the other kind of employee scheme, for example, ESI, CGHS, ECHS, etc. I want to, in the last, I'm sure you're getting short of time. In the last sentence, I want to utilize this opportunity actually to emphasize a point that actually government should why there is a need of running a ESI scheme separately. I have a very, very strong reservation on running a ESI scheme separately, CGHS, CCHS separately. All these schemes actually should be, without any delay, merged into Ayushman. ESI running a medical college makes no sense. It's an insurance company for that matter. ESI is an insurance company. They are sitting on a corpus of 50,000 crores. They're not paying people on time, and still they are opening medical colleges. They are spending money in infrastructure. Let the private sector spend money in infrastructure. Let the private sector provide services. And all these, they should increase the base of Ayushman, do work on a better pricing and on quality. That's the last comment I wanted. Thank you.
Thank you so much, Dr. Batra, Dr. Harish, and Dr. Nagar, for your wonderful work which you people are doing at every stage of this healthcare requirement, and have been serving the society, to the people at areas where it was non-existent. Thank you so much, Dr. Dinesh Batra, Dr. Harish Pillai, and Dr. Dharminder Nagar, for your wonderful work, your contribution. We are really, really thankful for whatever you people are doing for the health of this country. Thank you so much.